All right, we're going to go ahead and get started here, everyone. Thank you for joining us. My name is Melissa Morford, and I am Manager of Neuro Resource Facilitation here at the Brain Injury Alliance of Iowa. Today's webinar is called REAP, It Takes a Village, presented by Dr. Karen McAvoy from the Rocky Mountain Hospital for Children out of Denver, Colorado. This is our last webinar in the four-part webinar series regarding concussion management. So if you missed one of our previous webinars, those are available on our website at www.biaia.org if you'd like to see an archived version of that. I'd just like to quickly go over a couple of housekeeping items here. As you can see on your GoToWebinar control panel, you do have two options to listen to today's webinar. You can choose the mic and speakers option, or you can choose the telephone option. So if you have problems with either one of those, you can just go ahead and try to switch out the option. We will also be recording today's webinar and posting it to our website to be viewed in the following few days. And the PowerPoint slides along with the REAP manual should be available on your control panel if you'd like to go ahead and take some notes from today. We will actually go ahead and save questions to the end of the webinar. So if you have any questions throughout, you can go ahead and type those into the chat feature, but we'll go ahead and save those and I'll help ask those questions at the end. No CEUs will be provided for the webinar today, but a certificate of attendance will be emailed out at the end of the presentation. We will also be emailing out a link for our survey for participants to go ahead and share their feedback. I would now like to go ahead and introduce our presenter. Dr. Karen McAvoy is the Director for the Center for Concussion, coordinating and managing the Center for Concussion Clinic at the Rocky Mountain Hospital for Children in Denver, Colorado. Her responsibilities include evaluating and treating pediatric concussion, including consultation and training with schools, neuropsychological assessments and pain management, and individual and family support. She is also the author of REAP, Community-Based Concussion Management Project. Further, she is a consultant on brain injury with the Exceptional Student Services Unit, which oversees and assists the 179 school districts of Colorado with the training of staff and implementation of services for students with moderate to severe brain injuries. We are very excited to have Dr. Karen McAvoy with us here today to discuss the importance of the interdisciplinary team approach in REAP, the risks, signs, symptoms, and mechanisms of concussion and their potential impact upon learning, behavior, and emotions, ways to incorporate return to learn with return to play, and how to maximize recovery in the acute phase of concussion and how to help student athletes with protracted recovery. Thank you for joining us. I will go ahead and unmute our speaker here now so she can take over the presentation. Dr. McAvoy, can you hear me?
I can. Can you hear me okay?
Yep, we can hear you.
Okay, perfect. Well, thank you for the introduction and thank you for having me. Good morning to all of you. It's, I know, afternoon for you guys on Central Time. It's still morning here in Denver, Colorado. So I appreciate you having me on today to speak about REAP. REAP is, as you heard, an interdisciplinary team approach for concussion management that incorporates the four different teams that are essential in concussion management. The family team, the medical team, and the school has two teams, a physical and an academic team. And I have been given the task of an overview with this presentation today because, as I understand, there is quite a diverse audience out there listening, and many of you will fall on either one or a couple of these different teams. And so I will try to present different information for all of you, pieces that you might really resonate with depending on what team you're with. But because it's only an hour long, we won't be able to get into in-depth in any one of these. But just pique your interest a little bit in these different areas. And what we hope to do is to do some follow-up trainings next year on all of these various different teams more in depth. So we're working on that right now. And we're also in the process of customizing REAP for the state of Iowa. So hopefully this will be a resource that you guys can use in the years to come. So let me go ahead and start with just kind of the basic background on myself and the REAP project. I got into this world of concussion in 2004, and at that time, I was the school psychologist. I'm a clinical psychologist by training, but working in a school in a large suburban school district here in Colorado, and I was at Grandview High School when we lost a young football player named Jake Snakenberg to second impact syndrome. That was in 2004, and at that time, there really just was not a lot of information. But if you've been following concussion now, you know that there's a lot of information, lots of new research on concussion, um, from all the way from youth sports all the way to the professional athletes. So at this point, as I am now in my 12th year of doing concussion work, it's not a lack of information. It is more about a difficulty of implementation. And so, what we hope to do with the work that we're doing now is to begin to get the teams that are all working together on kids with concussion to begin to find a seamless way to work better together, to share information, because this is not something that can be done by one team alone, and that's why it takes a village. So as I said, my introduction into concussion came in September of 2004. This is a picture of the Monday newspaper after we lost Jake Snakenberg to second impact syndrome. He was a freshman football player at Grandview High School. We had just baseline tested our first group of football players like 2 weeks earlier, and Jake had taken a hit the week before. The only symptom he really had was numbness and tingling in his arms, and he was held out for about a week. But at that time, if you remember, we were still doing things like level 1, 2, and 3 grading. There was really no legislation. And so after a week or so, he was allowed to get back into play. And so Saturday morning, September 18th, he took a very small hit on the field. He collapsed, and then he was airlifted off the field, taken to the nearest hospital, where they informed his parents that he would probably not play football game again. But what ended up happening is that he never did regain consciousness. And so Jake passed away that weekend, and on Monday morning, my job as the school psychologist was to go into the school and work with the football team and the staff and the students on the loss of a student, and which happened to be from concussion. But really, we needed to deal with the trauma of losing this student. As a result of what happened in 2004 at this one particular high school, we ended up managing our concussions differently. We ended up pulling all together. Athletic trainer was talking to the nurse was talking to me, we were talking to teachers, we were talking to counselors. We were doing impact testing and sharing that every single time with parents and outside professionals, medical professionals, and as a result, we ended up creating a system by which information was flowing seamlessly in many different directions, and we were all sharing information. And so when I left Grandview High School in 2007, 2009, I sat down and wrote up REAP, which was really how we were managing concussions at this school, and put it into this acronym of remove and reduce, educate about the symptoms, adjust and accommodate throughout the recovery process, and eventually pace them back through physical and cognitive demands. And so the process of PACE then became kind of the acronym that we use in working kids through this process. But this is something that there's a part for every single team, and so we color coded everything, as you'll see in a few minutes. So you have a copy of the REAP, Colorado REAP book. Like I said, we are customizing this for Iowa and hope to have that for you by next year. And if you would like to download more copies of it, you can download it at Rocky Mountain Hospital for Children and just follow the prompts to REAP. As a result of what happened to Jake in our state and what happened to many other players in different states, you know that legislation went across the entire country, and all 50 states now have return to play legislation for youth concussion. And it incorporates the three tenets of education, removal from play, and return to play under medical guidance. Now, who needs to be educated will depend state by state. and who needs to be the medical provider in terms of return to play. That will also vary state by state. And while it's true that all states went forward with return to play legislation because of significant catastrophic events such as permanent brain damage or death in youth athletes, because this is not a phenomenon that we see in older professional athletes. So while all states went forward with return to play legislation, when you look at the research about concussion, though, the odds are really very good for a very good recovery. 40% of concussions will resolve in 1 week, 70% in 2 weeks, 80% will resolve in 3 weeks, and so we say about 3 to 4 weeks, we have an 80 to 90% recovery rate. That's what the research is showing. So yes, we do need to pay attention to those very serious and very rare outcomes of second impact syndrome, or subdural hematomas, but on the average, we are able to support 80 to 90% of kids recovering from concussion by just doing good management for 3 to 4 weeks. So that's really what REAP is focused on, is the positive side. What can we do? We know that it's possible we'll have another case of second impact syndrome, but we don't know which kid that will happen to, and so therefore we have to just cast a very wide safety net for all of our kids. So that's really the of REAP. The multidisciplinary team, or the interdisciplinary teams, as we've talked about, include the family team, includes a medical team, and as I said, that will vary state by state. And what REAP did in 2009 was really introduce that the school has to have 2 teams. It has to have a physical team, or some point people in the school that are really overseeing the athletic side of it, or the symptom side of it. And we also have to have an academic team, the educators who oversee the return to learn and what to do in the classroom. And so, the physical team could be your athletic trainer, it could be your coach, it could be sometimes be your school nurse, your athletic director. And on the academic side, it's sometimes your school nurse as well, sometimes your athletic director as well as an administrator, and oftentimes teachers, school psychologists, school social workers, and counselors. So that's the team that is working together. And so the trick of all of this, the challenge, is how do we get the team working together when not all of them are all working at the same pace at the same time. And I'll show you that in a bit. So before we move forward, let's just make sure we are all on the same page with definition of concussion. This is the consensus statement from 2012. And as you know, there will be a meeting again in 2016, and so this definition may change slightly. Basically, a concussion is any kind of a direct or not direct force to the head or to the body that shakes the brain, and it causes a rapid onset or sometimes a delayed onset of signs and symptoms that can evolve over a number of hours or days. For those of you that are coaches, for those of you that are certified athletic trainers, you know the signs and symptoms very well. A lot of the trainings have been to that. And when we do trainings to coaches, we're always very careful to really reinforce the idea that the signs are what you will actually see in the student. And so this is also very pertinent for the school nurse or for teachers who might be trained on how to look for signs for kids who are coming in from recess or kids who take a fall at PE. The signs would be what the student is actually showing you, whether or not they are actually admitting to feeling differently or feeling headachy. But you would actually see that they are stumbling, or they are repeating questions over and over again, or that there's a significant change in their behavior or personality. The symptoms then would be those questions that we ask. Are you having a headache? Do you feel like you want to throw up? Do you feel dizzy? Do you feel like you're going to fall over? And these are the things that many of our symptom checklists consist of. But some of our kids are either not aware they're feeling these things or can't put it into words, or in some of our cases are not admitting to these. And so when we do trainings to coaches and we do trainings to playground supervisors and teachers, and to parents, we really want them to focus on both signs and symptoms, because you as professionals know these kids very well and have a good baseline on them. back to the definition. A concussion is a functional disturbance, not a structural injury, and that is why it is not seen on a CAT scan or an MRI. This becomes a really important distinction to make for concussion management because it is about an energy crisis. So if you look at what's really happening to the cells in a concussion, what is happening is that with the hit to the head or the impact, the potassium will leak out of the cell, calcium will run into the cell, and it will render the balance of what's inside versus outside of the cell it to be out of balance and therefore inefficient. So therefore, this is a cellular injury that cannot be picked up on a CAT scan or an MRI. So we do a lot of trainings as well to teachers and parents about, if your CAT scan is fine, and we don't recommend that those be done routinely, but if a CAT scan looks fine or an MRI looks fine, that doesn't mean you haven't had a concussion. It is about the jolt to the head and then signs and symptoms, which are demonstrating an energy crisis within the cells of the brain. And the way that I always explain this when I'm working with kids or I'm doing trainings with teachers is that with a concussion, the student is a little bit like a car with a very small gas tank. And what we want, the idea that we want to really get them to understand is that you are quite able to drive a car that has a very little gas tank, but you need to drive it differently. And so the concept here is that you would be able to drive the car, but when you see that the car is beginning to run out and give you some signs such as overheating or the light goes on the dashboard, it means it's time to fill that car, and then you fill it and you can keep on going. So you drive it, fill it, drive it, fill it. And that's the concept that we want our kids with a concussion to understand. Because we want them to understand that with a concussion, they can get out of the garage, they can do some things academically and socially, but they just can't race at 200 miles an hour like they did before. And so it's really a balance of doing a little, learning a little, resting a little, reading a little, resting a little, work on the computer a little, rest a little. This whole concept of being able to manage the symptoms so that the symptoms are not flaring, crashing and burning, but that they are just waxing and waning throughout the day. So that's kind of the concept that we use in educating the kids, that it's an energy crisis and that the symptoms are helping to tell us the story of recovery. And lastly, the definition about recovery for concussion. In the 2012 consensus paper, it said about 7 to 10 days. Actually, we're finding that the recovery is longer for children and adolescents, a little bit more like 2 to 3 weeks, about 19 to 21 days. And that's important for our kids to understand because they're not going to turn the corner on this, not many of them, in 7 days, and therefore it will take a couple of weeks for the cells to repair themselves. And so therefore management and not overtaxing but allowing for recovery is an important concept. But those shades of gray are very difficult for us to get our heads around. We know that there are some risk factors involved in concussion. Obviously, playing sports is a high risk element there, and football, of course, is always the highest, but you can see that girls lacrosse and soccer is not too far behind, and the CDC has some statistics saying that bike riding could be fairly high and concerning. But we also know, for those of us who are educators, you do not have to be an athlete to get a concussion. Many of our kids are getting concussions in various other ways. And in our clinic here at the Center for Concussion, I ran the numbers last week, and we had about 50% of the kids that we are now treating received their concussion in a non-athletic fashion. So those are motor vehicle accidents, falls, assaults. And so therefore, this is not just a sports issue. This is an issue for all kids and for all of us as coaches, educators to have our heads around, because we need to take care of all of the kids as they return to school, even if they don't return to sport. So the factors that we're really looking at as we move forward with concussion and management is how do we balance because the research is showing that too little rest will lead to protracted recovery, and too much rest will also lead to protracted recovery. And so therefore, that shades of gray of how do we manage just the right amount in between, what can the student do and who helps them to do various things, is really the process of REAP. So if you are looking at management, as we go through the rest of this, try to think about which team you belong to. And note that everything is color-coded as we move forward. Everything that is for the school team physical is a light blue color. Everything that is for the school team academic is a darker blue color. And things that are for medical folks that are listening to this today, the medical doctors, the PTs, sports medicine, that's going to be in a dark green. And if you're listening from the perspective as a family member, that's going to be in orange. So in the beginning of a concussion, we all have a part to play in removing the student from any potential hit to the head, further hit to the head. So we remove them from all physical activity as well as recreational activity, and we reduce the stimulation that they're doing at home and at school. So everybody has a role here. This is the actual remove reduce page out of REAP, and you can see that it's color coded, and it outlines there what the role is for the family, for the medical team in terms of remove and reduce. You can see here that that's supposed to be light blue. It's looking a little darker blue on my computer, but the light blue part for the physical team is to remove them from all organized sports, recreational sports, PE, dance class, and physical play at recess. Even though PE is an academic class, it's probably wise to remove them from any potential hit to the head at PE or at recess at school. We ask the parents to be really partners in removing or reducing some of the home stimulation, but we can't really remove all of it. So we ask them to limit it, to limit TV, to limit texting, computer screens, and video games. And for educators, we work with them and train them on how to reduce the school demands that lead to mental fatigue, slow processing speed, and difficulty with learning. And those are the things that flare the symptoms at school. The remove from physical part, as we've gone over, if you're a coach or an athletic trainer or a PE teacher, your part in supporting these kids once we've removed them from play is often to be checking in on their symptoms, to be supporting them, letting them understand that this is a 2 to 3 week process generally, but they really can't be playing. And so there's a lot of support that's being done on the physical side. From the medical side, once a doctor or an emergency room has confirmed the diagnosis of concussion and looks for contributing factors such as ocular motor, vestibular issue, dysautonomia, convergence insufficiency, then again, your part in terms of allowing them to do physical activity is pretty set. They are out of PE, physical play, organized sports, and recreational sports. Now, there's a lot of new and very promising information for medical providers and physical therapists in terms of using vestibular physical therapy as a way to start to promote recovery for these students. And this vestibular physical therapy and early exertional therapy, this light cardiotherapy, has been very promising in helping with the effects of ocular motor, vestibular issues. The dysautonomia is the same as that postural intolerance, and with that we just increase water and salt and avoid caffeine and do a little bit of early exertional, and the convergence insufficiency we can do with vestibular therapy. So in our clinic we use a lot of vestibular physical therapy to begin to help these kids, and that was something that was done down the road. We're beginning to push it up to maybe the second week of a concussion, depending on how symptomatic they are, and that's really promising. But this is not something yet that we know exactly when to start it, how much to give, the dosage of it, and therefore we are still saying this should be done in a very supervised setting, such as physical therapy, not to be done in school, not to be done with organized sports teams, because it's still a very fine line of how much is the right amount of therapy. So you can see that in the early stages of a concussion, the physical team pulls them from play, the medical team pulls them from play. and maybe starts a little bit of the therapy. But really, the management of the concussion from week 1 to 3 is going to fall in the lap of what happens at home and what happens at school academically. And so you can see from this slide that while the physical team and the medical team may have a very huge part in the beginning of a concussion, once they pull them from play, then the management goes over to the educators and to the family, who has a bigger part in the middle, and then eventually this will go back to the medical team and the physical team for possible clearance and return to play. As I talked about, the majority of management is going to fall in the middle, with the families doing some very important things such as limiting texting and TV and video games, driving, keeping the socialization and extracurriculars down, and then the academic team doing some things about getting them back to school, but maybe removing some of their work, reducing some of their work, and pacing their mental demands. So that's really the process for 2 to 3 weeks of management there in the middle of the concussion. And as I said, these are all things that we can do lots more training on down the road, because each one of these could be its own training by itself. And so once all the teams know what they're doing, we really educate everyone that these symptoms tell us the story of the recovery of the concussion. And that's how we know when we're getting progress. And so the symptoms, as we talked about, we need to know the signs and symptoms of symptoms, but we also need to recognize that there are 4 domains. And we talk a lot about headaches, but we don't want to forget that with many of our students, we are seeing cognitive symptoms where they can't remember or they can't concentrate well, and we're seeing some emotional symptoms where they are much more irritable. They're much easier to go off and cry. And so we have to be really cognizant of the emotional and cognitive symptoms as well. It's not uncommon for our kids to have some issues with sleep and energy. And so they'll either feel very fatigued or they'll have trouble maintaining sleep at some point. So we really want the parents and the teachers to understand that the symptoms, we shouldn't panic about them, but we do need to use them to help direct our interventions and also to help know if we are getting traction with recovery. This is a page out of REAP as well that gives you a 1 to 3 week time frame and how everybody would be watching and assessing symptom recovery over those 3 weeks. And you can do that by symptom checklists. And as they continue to get better, we want them to continue to move forward with their ability to keep testing the waters, dipping their toe in water, and trying some new things out at home and at school. As long as it's not physical, the physical piece, we want only a physical therapist or a medical doctor to be overseeing that, or an athletic trainer. So management at home, as I said, has a lot to do with how much of the visual stimulation they're getting and socializing and extracurricular. And while it's not possible to restrict this completely for too long, that's not realistic at all, we do use the gas tank analogy to remind kids that if you're going to add these things back in again, add everything in small increments. Watch one TV show, then get a drink of water, then come back and do something different. Get on the computer for 30 minutes, then get a drink of water, walk around the house. And so just keep breaking it up so that we're always doing, filling, and never overrunning the brain too much. And with that process, we're hoping to keep the symptoms at bay and not let them ever get too big. Eventually, you'll find you can go for longer periods of time with less rest breaks, and it's just kind of a natural way to move forward in a rehab model. Returning to school, returning to learn is really a very difficult part of this. And for those of you that are educators that are listening, I adapt a lot of my trainings from the Get Schooled on Concussion website, which is it is a website with one-pagers written for educators, written by educators to really help with this concept. While it is true that we want kids to be 100% symptom-free before they return to play, it is not necessary to be 100% symptom-free before you return to school and return to learn. However, we do need the schools to feel comfortable receiving these kids back and know how to handle them. The research shows that it's important for kids to be back at school for many reasons, not just for learning, but for social and to combat anxiety and depression. And so the Halstead article in 2013 said that kids should go back to school when symptoms are tolerable, intermittent, and amenable to rest. The Thompson article did a comparison between kids coming out of an emergency room. A group of them went into the group that said rest for 1 to 2 days and then gradually return to some activity, not physical, but going back to your normal life with socialization and school. And then the other group went into a 5-day complete rest group. The symptoms that they followed over time showed that the kids who had a 1 to 2 day rest with gradual return did better than the kids who had a 5-day strict rest. So that also is research that says we should get these kids back to school for many reasons. This is the REAP Return to School page that helps parents figure out that if the kid is very symptomatic, that they can't even concentrate for 10 minutes, then they probably need to be home on bed rest. If they can concentrate for up to 20 minutes, then they can start some light mental activity at home. And then if they can concentrate and have periods of time where they are fine for 30 to 45 minutes, then they need to consider returning to school with the school ready to receive them. So this is an article that I wrote for the Communique, which is the newsletter for the American Academy of School Psychologists, on what schools, teachers, school nurses, school psychologists need to know as these kids return to school. You can see that there are the 4 domains of symptoms, and then there are interventions that go with each one of them. And that's, of course, using the symptoms to help to direct the interventions. But it's also an article that helps our educators understand that underneath the symptoms is mental fatigue because of that energy crisis, slow processing speed because everything you do, you have to do it smaller increments, so you just won't cover as much ground that way, and difficulty converting new information into memory. So it's an inefficiency of learning, and having that understanding will help our educators be able to be richer and wider in their interventions that they offer at school. So if you break down the 3 big ones, mental fatigue is the biggest issue. So for some kids, if their cells are so inefficient that they can't even be at school at all, they might be out of school for a number of days, but we don't want that to be too long. Once they're able to be managing school, they might be at school either with that idea of taking breaks, or if it's really bad, they might need shortened days. But again, we don't want that to be too long. The main intervention for mental fatigue is having kids be at school, but every 30 minutes or 40 minutes or so, that they take a little eye break, head break, put their head down in the classroom just for 5 or 10 minutes, or get a drink of water, or go to the bathroom, and just keep breaking up and refueling. So that's the concept of do a little, rest a little. There can also be 20-minute strategic breaks in the clinic, mid-morning, mid-afternoon. And then, of course, there's all the things that you do to support the symptoms that would really help to make the child feel more comfortable. So if they have oculomotor issues, then large prints would help on their books. If they have eye strain, then they need to really pace how much they're looking at the computer. It's not that they don't look at the computer, and it's not that they can't read, but they have to do it in a different way, in smaller increments with many more rest breaks. If they're having vestibular issues, which is the movement of your head, then looking up and down from your board, from the desk to the board, could be tough for them, or passing in the hallways could be too overstimulating for them. So there are these things that you can do to help with that. Dysautonomia, as I said, causes the faintness, the tiredness, and with that we just increase water and salt. And then, of course, you'll see emotional reactions from all of these students because they're just mentally fatigued. They're just running on empty. That's a pretty common thing that you see. Everything is just a bit heightened and exacerbated. The slow processing speed, of course, comes with having to kind of cut back how much you're presenting to these kids or how quickly they're moving through it. So that then means that it would be very helpful to cut back the amount of work. Consider removal of non-essential classwork, consider reduction of semi-essential classwork, and really trying to figure out what we need to really cover at this time. Go for quality, not quantity. Give some extra time on some work if it is absolutely essential, but do not adjust all dates, due dates. Do not carry over all work. One of the biggest mistakes that I see that educators give is they will often put down work for now, but say, here, you can do this work later when you're done with your concussion. But 2 to 3 weeks later, they have to jump back on with current work as well as makeup work, and it's not possible for them to do all of that. So that kind of stress will actually delay the recovery, and could lead to other things with kids. So therefore, removal of some non-essential work so that when they jump back in, they're feeling better. It's a reasonable amount of work, and they can get back on track. So that's what we would recommend with work. And then difficulty learning new material really is a process by which teachers need to figure out what is most important to continue teaching during this time. I want the student to really learn these 3 concepts, even though we have 3 weeks when they're not at their best. And then how would I make sure they have mastery of that? How would I make sure I can give them a grade or test them on that? And we'd want the educators to be really cognizant of the fact, was the student physically and cognitively present? Did they learn the material? And do they need to show mastery on this by a test? Could it be an alternative project? So how could we still make sure we have mastery and can give a grade during a time when the student is somewhat compromised? So that's what we would say for new learning. So there's many more ideas in the Get Schooled website, and like I said, this could be a full day training for educators. Of course, looking at the symptoms and trying to really adjust your interventions for the symptoms is important. And so this is the symptom wheel out of the REAP book, and you can see that this would, of course, be helpful for your teachers to even start there. And we would recommend that the teachers front load the interventions and know that this is usually a 3-week process, so be more generous with the interventions in the very beginning of the concussion when the symptoms are highest, and when the student is just re-entering, begin to slowly pull back the interventions if they're not needed over time, and try to move the child back to almost to full academics by the 3rd or 4th week. So this would be a typical concussion over 3 to 4 weeks. And the good news about concussion is that, as we said, it's a pretty typical recovery with 3 to 4 weeks at 80 to 90%. So therefore, as symptoms decrease over time, the ability to add in activities will increase over time. And it's just a process of being able to know how to read the symptoms so you're moving forward at the appropriate pace, not too fast and not too slow, to continue to rehab this student through this process of management. So the REAP A stands for Adjust and Accommodate, and this whole process is to really help families and school teams cut back but move forward over 2 to 3 to 4 weeks. And of course, it's always safer to test symptoms in these ways, these safe ways first. If you add in a test and it flares a headache, then we know we've still got a mismatch of energy there, and we back it down but add it again in a couple of days. Same thing with, we say to parents, try a busy restaurant. So we're just constantly testing, using the symptoms as a way to move them forward before we start the physical part, which is, of course, the most concerning part. This whole process will help you collect your data from the family and from the school educators to know if they are safely moving forward, managing the symptoms, promoting the recovery, but providing information to the medical doctor or to the certified athletic trainer to help begin to decide when is a safe time to start the graduated return to play. Somewhere about week 3 or 4, we hope that this all comes together. So this is a page out of REAP that helps you know which questions you're really trying to look at before you start the graduated return to play. And basically we say, are they 100% symptom free? Is that the data that you're getting from the parents? If they've cut back, have they added back in and they're fine now? That's good information. Are they 100% symptom free at school or back to their baseline? So are their teachers reporting that they cut back their work, but now they're back to doing all the work that they were doing pre-concussion? That's good data. If the school's doing neurocognitive testing, that can be used as well, but not all schools do that. And if you don't have baseline, is this student back where you think they should be in the normative range? If a certified athletic trainer is working with them, are you doing symptom checklists, and do you feel comfortable because you have baseline on these students? And if a physical therapist is working with them in vestibular therapy or manual physical therapy, do we feel comfortable there? And are they off all medications, over-the-counter medications that we use to treat the symptoms of concussion? If the answers are yes to all of this, then it seems like we have the data that we need to start to move them forward on their graduated return to play. So from this point forward, the medical doctor may approve the graduated return to play, or in some states, depending on your clearance process, an athletic trainer may be the one to decide the start of the graduated return to play. A word of caution here, the student has to be 100% symptom-free before they start their return to play steps, and that then implies that they are 100% back to learning. So any students that are still needing academic support would not be considered symptom-free to start their graduated return to play. So there's no return to play until 100% back to return to learn would be the mantra there. If you all do decide it's time to start to return to play, here are some resources that will help you collect your data. This is, of course, a symptom checklist. There are many out there. This is one out of REAP. The other thing that we have put in REAP and that we use in our clinic every day is the teacher feedback form. If this is a student who wants to go back to sport, we ask the student to go talk to every single one of the teachers and have the teachers answer these questions, which basically gives the teacher a chance to let us know if they feel the student is 100% back to return to learn. We use this in our clinic with all students, not even just those that want to go back to sport, but any student who wants to clear before we start them on the graduated return to play steps. And we put our non-athletes through those steps as well. So this is another step that will help you, if you're a school administrator, to collect the that shows cognitive recovery, helps you as an athletic trainer to make sure you know that it's the right time to move forward. And this is in the REAP book as well. You can use this with your teachers. Basically, we've been talking about the acute phase of concussion, which is the first 1 to 4 weeks. We consider that the acute phase, and during that time, schools have a responsibility to be working these kids back through that acute recovery, and medical professionals are working to find ways to reduce the symptoms and promote recovery. Beyond that time, there should be in schools a system by which you can refer on for ongoing support. Almost all schools, I would say, have a system in place when a child is struggling with learning or behavior that needs ongoing intervention or assessment. That process of problem-solving teams, flex teams, house teams, and it's often part of the multi-tier system of support or response to intervention system that educators use. You want to make sure that your kids with concussion that are not getting better beyond 4 weeks have ongoing supports academically, and that you have a medical provider involved helping to figure out why they're not better in that 4-week time. If 90% of kids get better in 4 weeks, 95% of them in 5 weeks, having a student who is 6, 8, 12 weeks out still symptomatic is quite a medical outlier, and you're going to want to be partnering very closely between the medical doctors, the family, and the school to figure out why that student is in that small percentage. There are students who have longer recovery. There are concussion modifiers that would suggest longer recovery, like a history of headaches, migraines, past concussions, learning issues, attentional issues, neurological issues, anxiety, depression. And then those kids that we find that have ocular motor, vestibular issues, dysautonomia, or vision issues such as convergence insufficiency, those all might take longer to recover because it's just a strain on the body. So if there are these reasons and the team understands that, you can continue to support medically as well as at school for a longer period of time. But you're really going to want to understand that, because it's only going to be 10 to 20% of your kids who need to go on to that level of intervention. You're hoping that with good management that we've talked about with REAP, 80 to 90% of your kids have been supported well and will end up clearing with just this interdisciplinary team approach. The one thing you want to watch out for is that some kids do not get better because there's some underlying school avoidance or truancy issues, and while that's not concussion related per se, it definitely is something that's going to confound your ability to clear them, and so therefore that has to be worked through as well with your school psychologist or an outside counselor. So this really supports then why it's so important to have the school medical family partnership. Medical professionals are critical in helping to identify the underlying issues, or a psychologist, or, if it's a psychological issue. Um, but the school professionals then take that information and they need to be the ones to decide what's an appropriate academic support. And that can be done through their house team, their multi-tier system of support, whatever it is that we do, because we support all kids, whether for all learning and behavioral and physical and medical issues, um, and no matter what that is, diabetes or seizures, we're able to do that. So we just need to work together to know what the ongoing problems are, and then the um, the school will support that. Return to play legislation at this point only covers athletes, and as I said, there's an increasing number of non-athletic mechanisms for concussion, and increasing number of families that are not going to medical care. So therefore, the school needs to be well versed in being able to support all students, no matter how they got their concussion, no matter how long this is going on, because that being able to support them, even if you don't have good or relevant medical input, that will fall on the school. So we do a lot of trainings for educators, because this is something that will fall within their scope of work. As I said, educators already have a system in place called the response to intervention, or the multi-tier system of support, that helps with behavior and academics. So all I did is I took concussion and put it on there. And if you see that even with behavior and learning, 80 to 90% of the kids will do well with good management in general education. We call those academic adjustments. Those interventions that we talked about with concussion are academic adjustments, and those should be provided immediately, flexibly, and fluidly in general education for kids with concussion. If they're needing to go on, that's that 5 to 15% where they're having continued issues, goes on maybe to a more formalized plan, maybe a 504. It doesn't have to be. And those would be called academic accommodations. Same interventions, but just put in a more targeted way. And then that very small percentage of kids that do not get better because they have permanent brain damage as a result of concussion, that would go on to special education, and those would be academic modifications. It is incredibly rare that you would ever have a kid get all the way up to tier 3 and need special education for a concussion, because generally it's just not a permanent brain damage. It's transient and, like I said, has a very good recovery rate, but it's possible that a very small percent would go on to special education. So as educators know, there is a system in place to help these kids no matter what level they fall at. I keep referring to the Get Schooled on Concussions website. Here is a link to that. And as I said, this is specific for how to get more information on for teachers, written by educators, written for educators, and there's a whole process in here that would help an educator know when to write a 504, how to write a 504, which would be more than we could go into in today's training, but there's definitely more guidance as you move forward. So in conclusion, I think it's pretty safe to say that all 4 teams have a very important role in concussion management. As we get done with management and the family team and the educational team gives it back over to the physical team or the medical team, they take that forward, start the graduate and return to play, do the physical steps towards clearance, and then this student is safe to clear. You can see how it's a passing of the baton where various points, different teams need to take the baton and run with it, collect data, and then give that data to the next team to make sure it's safe to move forward. So we use REAP in the clinic that I work at. We have a medical doctor, I'm the psychologist, we have an athletic trainer, and everybody that comes into this clinic is seen by all 3 of us every single time, and all of that is coordinated back to the school with a phone call or email every single time. So in the clinic, we use the REAP model. At a school, you also have these same factors. You have the 2 teams definitely within the school, the physical and academic, that need to be talking to each other the whole time, and then a process by which you're talking to the family and communicating with the medical team, so probably needing a release of information for HIPAA and FERPA. So this is just an entire community-based approach. And that's why we say it takes a village. It's not a hard, it's not a hard process. It is, but it's a very complicated process because it requires so many moving parts and everybody working so well together. But it's a very rewarding process in that 80 to 90 to 95% of these kids can get better with a systemic and sustainable process in your community or in your schools that will help to promote recovery of the majority of your kids. And then you're working with the smaller percentage that have ongoing other underlying issues that need more targeted or intensive interventions. So I think I'm going to stop right here and allow for some questions. I think that Melissa said to go ahead and add those into the chat box, or you will direct those questions to me, Melissa?
Yep, that is correct. So if anybody has any questions, you're welcome to go ahead and type those into your chat feature there, and I will help ask those questions. But in the meantime, as people are asking questions, Dr. McAvoy, we again thank you very much for sharing some of this information with us here today. I guess a lot of the conversation is beginning to kind of take shape here in the state of Iowa regarding concussion management. So your insight is very valuable to us. And again, as Dr. McAvoy mentioned, for those of you that are listening here today, we are in the process of creating that Iowanized version of the REAP Concussion Management Protocol Manual to be available in the future. So the handout that's available on your GoToWebinar control panel is the Colorado version. But again, we're working on that Iowa version here. So questions, kind of looking things up here at the moment. One question I guess we did have emailed to us. Can you, I guess, provide a little bit more insight on some different baseline assessment tools that have been used in the state of Colorado, or any insight that you might have on that?
Sure. There are different kinds of baseline tools. Obviously, the neurocognitive tests, the most recognized one is the impact test, which comes out of Pittsburgh, which provides a neurocognitive assessment on the computer usually for athletes in the areas of verbal memory, visual memory, processing speed, and reaction time. They sit down, take that test before they ever go out on the field, and then if they have a concussion, they come back in to take the test, and they're able to take up to 4 post-concussion tests, and you can compare their post-concussion scores with their baseline scores to monitor recovery. So impact, of course, is the neurocognitive test. In neurocognitive tests, there was also the Axon, there was also CNS vital signs, and so there are a couple of other companies that do neurocognitive as well. There are other baseline assessments, so if you can't do the computerized version, they would recommend that you even just maybe do the SCAT-3 on an evaluation or pre-participation evaluation, so that you have some baseline on some mental status, that's just the SAC part of the SCAT, and some balance baseline. And then that way, if they have a concussion, you can compare back to that. So with balance and with just memory questions is another way to do that. And then there's, even just doing symptoms at baseline and then post-concussion doing symptoms is another way to look at the difference. So there are a couple of different measures out, not always neurocognitive, but balance as well. The King-Devick is another way which is kind of an eye exam to look at pre-post.
All right, good deal. Thank you. We did just have another question come through here. What are your feelings on adding the VOMS testing?
So the VOM is that vestibular ocular motor testing. I would say that our feelings here in the clinic would be that is really the wave of the future here for concussion. When we started the clinic a number of years back and we did not know as much as we know about vestibular and ocular motor, we were just asking kids to rest for a couple of weeks. Now we know to look for that. We do that evaluation where we're looking at eye tracking, we're looking at saccades, we're looking at the jumpiness of the eyes basically. And when we're finding that on our evaluation in the first week or two, we're referring to vestibular therapy right away. And vestibular therapy is able to start working with these kids in a PT setting, as well as give them home exercises. And in a couple of weeks, you start to see those things really get better. So I think it's huge, and I don't think that I could do concussion management without really good assessment in those areas, as well as rehab and treatment in those areas.
All right, thank you very much. I don't see any other questions here at the moment. We'll maybe give everybody about 30 seconds here more to just have a chance to type in any additional questions they have before we close up for the day.
Okay.
And for those of you that do have questions later on, you are welcome to contact us through the Brain Injury Alliance of Iowa as well. Our email address is info@biaia.org. I'm doing one last check here. I don't see any other questions, so I think we will go ahead and wrap up the webinar here for today. So just, again, a thank you to everyone that attended. And again, the webinar has been recorded, so this will be available on our website here in the next coming days. We will be sending out, again, that certificate of attendance just within the hour or so after the webinar has ended. And we do ask to make sure that you take time to complete our survey for the webinar. All right, everybody, thank you very much. Have a good day. Thanks, Karen.
Thank you. Bye-bye.